Welcome to the quarterly Airway Research Update with Dr. Calvin Brown.
Thank you very much, Terry. Hello, everyone. It's great to be here with you all today. My name is Calvin Brown. I'm the course director for the Difficult Airway Course Emergency, and I work clinically as an emergency physician at Brigham and Women's Hospital. In fact, this is the first post-overnight version of Airway World, so should be fun. We're still going to have a good time. I'm still going to be chipper, but I'm working on 3 hours of sleep. I'm sure some of you out there have been up all night as well, so I appreciate you being here. I'm an associate professor of emergency medicine at Harvard Medical School, and I really enjoy doing these quarterly research updates. Just going to advance the slides here. I have no disclosures, as you can see on the screen. This webinar has been approved for 1 AMA PRA Category 1 credit, 1 hour of CAPC advanced credit, and everyone in attendance will receive a certificate by email within 2 weeks. Now, as we go through the webinar, I encourage everyone to post comments, ask questions. I'll do my best to get to those questions as we go through the presentation. We'll have a little bit of time at the end to answer those as well. There also are a handful of polls peppered within the presentation, of course, and a pre-test and post-test, which you will contribute to. If you've taken this webinar before, you know what I'm talking about. Okay, so what are the objectives for this webinar? Well, we want to keep you up to date on the latest airway research. And then, of course, the most important thing is to help apply these findings to your practice. So for each paper that we review, we will show you a sort of high-level summary of the methods, what the conclusions are, what the take-home points are, and any limitations. So here's the agenda. We have a quick pretest. We have a research review. This will be case-based, and there are 3 new papers to review. Q&A session can really happen at any time, but we will reserve some time at the end to make sure that we get to everyone's questions if they want to post something. We have post-test questions and then an evaluation upon exit from the presentation. All right, so let's go ahead and get started, and we will begin with a short pretest as we usually do. And you will get an idea of the topics that we're going to tackle based on the pretest question. So here's the first one. How often is post-intubation sedation appropriately initiated after emergency department RSIs? So after emergency department intubations, how often is post-intubation sedation administered? Now, I know you're all thinking to yourself, well, 100%, because why would I not give someone sedation after I intubate them? Well, it doesn't quite happen at 100% rate. And you know I will not divulge how everyone's answering in the pretest because this is just really for me to see how the audience is thinking about these at this point, and then we'll ask you similar questions or the same questions at the end. All right, well, there's a little bit of a spread here, so I think there's a good opportunity for learning on this topic. So let's move on. So dovetailing off of that first question, let's do a follow-up question about post-intubation sedation. What might be a risk factor for not receiving post-intubation sedation after RSI? Head injury, use of rocuronium, hypotension, or all of the above? Okay, well, it doesn't look like necessarily I'm fooling anybody with this one, but oh, now that more people are answering, it's actually spreading out a little bit more. So good. All right, let's move on to our third pretest question. And I struggled with this one a little bit. This is a little convoluted, but I hope that you'll get the idea and understand the selections here. Which of the following is true regarding apnea time and the order of administration of RSI medications? So A, when the induction agent is given before the neuromuscular blocking agent, the apnea time is prolonged. B, the neuromuscular blocking agent should be given first, since that reduces the duration of apnea. C, neuromuscular blocking agent should be given alone, since that results in the shortest period of apnea. Or D, the order of RSI meds does not influence the apnea time. All right, also a pretty good spray of answers, so I think this will be an interesting paper for everyone to take a look at also. All right, and let's move on to our last pre-test question. Which of the following is true regarding the Heaven criteria for difficult and failed laryngoscopy? A, Heaven is used to predict the likelihood of patient death following emergency intubation. B, 4 or more Heaven criteria means that RSI should not be performed. C, if a patient is completely Heaven negative, and you can probably tell that Heaven is a mnemonic, which we'll go over obviously, then direct laryngoscopy has better first attempt success than VL. Or D, airway difficulty directly correlates with the number of positive Heaven criteria. Not necessarily fooling anyone with this one also. Maybe I need to write harder questions. All right. Well, we're done with the pretest, so let's dive right in. So as I mentioned, we have 3 new studies today. We will present a clinical vignette to facilitate discussion. And as you may have guessed from the pre-test questions, the topics that we're going to tackle in these 3 papers include pre-hospital airway difficulty and the prediction of airway difficulty, RSI drug administration order, so neuromuscular blocker before sedative doesn't seem right, but is there a reason to do that in some patients? And post-intubation sedation. I think the results from that paper may surprise you a little bit. Okay, so let's start with a clinical scenario. So imagine paramedics arrive on scene of a multi-car accident with rollover and at least one victim having been ejected from his car. Now, appropriately, the paramedics pay most attention to the ejection patient since they tend to be horribly injured. And this patient is no different. He is alive but mangled and has a GCS of only 5. Blood pressure is 86 over palp. He has obvious mid-face trauma and blood in his airway. He is obese. A cervical collar is placed and face mask oxygen is applied. Now with that, his saturation is 90%. Now once in the helicopter and they take off and get en route to the hospital, intubation is undertaken for clear reasons: depressed GCS, hypoxia, and expected clinical course. So look, I'm not going to stress your neurons with this question, but is this a high-risk intubation? Yes, no, maybe so. This is something I think we could probably get to a quick 100% agreement on. Yeah, so this was not a trick question. Just by seeing what the case was about and listening to all the different aspects of the patient's presentation, this is clearly not a garden variety intubation. So how do we know that? How can we reliably predict these things in the pre-hospital setting? Because that would be important for clinicians. Well, let's talk for a few minutes about Heaven, and not necessarily where your patient is going to go or not go after you manage their airway, but just let's talk about the Heaven mnemonic. So we have reviewed a Heaven paper previously, and I refer you to old webinars to review one of the original Heaven papers. And Heaven is a pre-hospital mnemonic to predict difficulty with airway management. And in this paper, and I'll show you the title in just a second, the Heaven mnemonic was looked at and analyzed for its predictive ability to find difficulty with both direct laryngoscopy, video laryngoscopy, and its impact on first attempt success. So in contrast to the first paper, this is a little bit of a deeper dive at how the mnemonic performs for pre-hospital airway management prediction. So here is a clip of the PDF title. It's entitled "The Heaven Criteria Predict Laryngoscopic View and Intubation Success for Both Direct and Video Laryngoscopy, a Cohort Analysis." So let's go over sort of the nuts and bolts of the paper first. And there was a lot written about in the methods because there were a lot of options that the operators could undertake depending on the patient's screening by Heaven criteria and how that impacted their decision-making and the way they managed the airway. So this was a retrospective review of air transport RSIs. And this is not dissimilar to NEAR necessarily, which is the National Emergency Airway Registry, which I run here. And actually, there's a NEAR paper coming up at the end of the webinar. But this is basically a multi-center, multi-base observational registry of air transport intubations. It is framed out of 160 bases across the United States. And RSI was the standard protocol that was utilized for all non-arrest intubation. So if the patient had awareness, had vital signs, and required sedation, they went ahead and went with full RSI with sedation and neuromuscular blockade. And then the Heaven criteria were assessed by having these things read aloud and marked off on a checklist prior to administration of rapid sequence intubation medications. So standard RSI drugs were used, and by that I mean they had pretty standard induction agents that they could select from, etomidate, ketamine, etc., and then they had standard neuromuscular blocking agents, succinylcholine, and rocuronium. The device that was used was up to the operator, as I understand it from reading the paper. They could have started with a direct view of the airway or a video-enhanced view of the airway. The device they used was a MAC4-sized CMAC, which, if you've used a CMAC before, of course, gives you the ability to perform direct laryngoscopy if you just want to turn the screen around, or use the screen if you happen to have trouble. So if the patient was screened Heaven positive for certain things that might impact the speed in which you need to place the tube, then it was suggested to the operators that they use the direct view. So, for example, someone who was already hypoxic, someone who had exsanguination, where the anatomy was not necessarily expected to be super difficult, but some of the physiologic abnormalities were expected to be tough, and tube placement would need to be very efficient. It was suggested, although wasn't mandatory, that the operator use the direct view. If the patient was Heaven positive for anatomic problems, then VL was the device or the technology that was suggested. One of the advantages that the authors mention in the paper, which I do agree with, is that the Heaven criteria, which I'll show you in a minute, takes into account both anatomic features of airway difficulty and physiologic abnormalities that can also complicate airway management, which some of our more traditional airway mnemonics and things that we teach at our airway course, like the Lemon, Roman, RODS, and SMART mnemonic, take into account mostly anatomic features, but I think we are realizing these days that abnormal physiology may be the most sinister thing that can creep up on you during airway management these days. Bad anatomy, for the most part, has been taken care of by video technology, but it's deranged physiology that tends to kill more patients. So one of the benefits of this mnemonic is that it takes into account some physiology, not all physiology that can get you into trouble, but some, and anatomic abnormalities as well. Now, if the person was Heaven positive, there were also other suggestions built into the protocol. So, for example, if someone screened positive for one or more of the Heaven criteria, and I'll just go ahead and show you the, actually, you know what, it's on the next slide. I'll get to it in just a second. If the patient did screen positive for one or more elements within Heaven, other things were also suggested from a process standpoint, in addition to whether or not VL or DL was used. So they did suggest to the operators that they have a low threshold to use external laryngeal manipulation, anticipating that laryngoscopy would be tough. Again, wasn't mandatory, but was suggested. It was also suggested that a bougie be handy, right? That makes sense. Access to an extraglottic device and a surgical airway kit also makes sense. But one of the things that was really interesting is that a laryngoscopic technique was also suggested. And I'm not sure exactly where this comes from. However, in the paper they mention that if a patient screened positive, a deep non-visual insertion of the blade first, followed by a visual withdrawal of the blade, was the suggested or preferred insertion technique. So instead of doing epiglottoscopy and looking for the epiglottis on the way in, it was mentioned in the paper that they suggested fully inserting the blade, lifting and withdrawing, and looking for the glottic inlet on the way out. And that may have an impact on some of the results that we're going to discuss. Okay, so how big was this study? It was a good-sized study. So even though this was not a randomized controlled trial, you often can get over some of those limitations of not having an RCT by having very big numbers. So they have big numbers. 5,137 encounters were analyzed. There were slightly more than that were eligible to be analyzed, but they removed awake intubation. They removed incomplete entries. The primary endpoint, sorry, I should have superscripted that degree sign, but the primary endpoint was intubation success without hypoxia, and glottic view. And they dichotomized glottic view into good or bad. And good was a Cormack-Lehane grade 1 or 2 view, bad was a Cormack-Lehane grade 3 or 4. They then performed uni and multivariable analyses to look for elements of heaven that might predict difficulty with first attempt success. Now, overall, just to give you some high-level information, the overall success rate within the registry was 88%. And the first attempt success, that's what FAS stands for, is 73%. Now, these numbers are on the low side, but just recall that we are talking about an environment that is not optimal in many cases, right? Patients who are being flown somewhere, you're in a tight compartment, you're in a helicopter, so this is not outside the realm of what we've seen in other airway registries that involve pre-hospital intubations. In fact, we had a near paper that was published from a large air transport company out of Missouri a number of years ago, called the A-Team paper for Air Transport Emergency Airway Management. And we found actually fairly similar results with an overall success of 91% and a first attempt success of 77%, so within the same ballpark. So what are the elements of heaven? So you can see on the left-hand side there that heaven is made up of several things. The first is hypoxemia. That's the H. The E is extremes of size. So this could mean multiple things. This could be a pediatric patient. It could be a large adult. It wasn't, it's sort of open to the operator interpretation a little bit. This one's challenging too. The A is anatomic challenge, and this is really another list, right? It's a list within a list of anatomic things, any anatomic things that you think might challenge your laryngoscopic attempt. So large tongue, reduced mouth opening, upper airway mass, those sorts of things, and probably others. The V is vomit blood fluid. E is exsanguination. And N is neck mobility. So that's heaven. You can see in table 1 here, which is on the right-hand side, the demographic data for each category. So the categories are broken down by DL, VL, and both DL and VL. Now, both DL and VL is interesting because the suggested approach is that once the patient is screened by heaven via the checklist, the operator makes a decision then if he or she is going to intubate directly under direct vision or using video. So how did 667 patients end up with a recorded direct and video view? And although this is not outlined in the paper, is very interesting. And what I think likely happened is that when you are intubating with a device that allows you to look directly or at the video screen, if you are having trouble with direct, it's very easy to convert the intubation attempt to video by simply turning the screen around. And this would give you the ability to report both direct and video glottic views. And so you would have both a DL, the DL, VL, and a DL and VL category. And I think that's important because if it is the fact that 667 direct intubation attempts were converted to video, that means that half of the patients who started under direct vision within a direct view attempt were converted to video. And that's important when you consider the difficult laryngoscopic view results, which I'll show you in just a minute. But in terms of demographic data, if you look across the table, the groups were fairly similar. That's the point of Table 1. Okay, so we're going to start to review a couple of bar graphs. And I will walk you through these bar graphs. They look like they'd be easy to interpret, but there's actually quite a bit of information buried in what appears to be a fairly simple bar graph. So the first that we're going to look at refers to difficult airway view and how the individual and collective Heaven criteria seem to have an impact on the view you can anticipate when you're intubating someone in the pre-hospital setting. So you can see at the bottom there are the Heaven criteria on the that are individualized. This is on the top graph. So hypoxemia, extremes of size, all of those, and the numbers that fell in each one of those categories. The dark and light bars represent within each of those categories the attempts that were done by DL and VL and whether or not that particular category was present and the impact on difficult airway view. So the way to look at this, see there's a lot buried in there. If you were to look at the difference between the dark and the light column in any one pairing, what this really tells you is the differential impact of that particular Heaven criteria on that particular device. So you can see here what I've highlighted or shown with the bracket is the difference in difficult airway view, that being Cormack-Lehane grade 3 or 4, with DL when anatomic challenges are present versus absent. You can see there's a 30 or 40% difference. So this is not an unexpected finding that anatomic challenges impact direct laryngoscopy pretty heavily. They also seem to affect VL if you look over to the very next pairing. The differences in height between any single colored bar within one of the Heaven criteria shows how VL and DL are differentially impacted by that particular criteria. So one is the difference between device, the other is differences within one device for each category. The one thing that's very interesting, which I'll get to in just a second, if you look at the bottom graph, this is probably the take-home message from the whole paper, which is that when you look at the individual elements of Heaven, you can see that there's an impact, but as you stack them up, so you start to add Heaven criteria, the impact becomes magnified. So the more Heaven criteria you have, the more likely you are to run into a difficult airway view, which makes sense, right? I mean, these things within Heaven are all things we know can impact airway management. So it's not necessarily a surprise, but very nice to know that when you start to add them up, the impact is logarithmic, essentially. It's really linear, but I like the word logarithmic. The thing that is interesting about this paper, which I struggle with, is why VL, and DL for that matter, performed so poorly. And what I mean by that is if you look at the percentage of difficult airway views with VL on that top table in any one of the categories, it's really high. There are not a lot of other airway studies out there that look at glottic exposure with video laryngoscopy that shows a Cormack-Lehane grade 3 or 4 view anywhere near these levels. So even with anatomic challenges, they found in this paper that 40% of patients they attempted to intubate with a video laryngoscope, so with the CMAC looking at the video camera, had a Cormack-Lehane grade 3 or 4 view. That's an order of magnitude higher than what you find in other papers. So it could be that the environment is so austere and the operator position and the patient position and just the setting in which they have to perform intubation is so awkward that this is just what you get. And that may be true, and the authors mention that in their paper. But one thing that's a possibility is that, especially in the for direct laryngoscopy, it may be that DL, if it was challenging at all at the beginning, may have been aborted. And it may have been aborted because this is a critically ill patient and you can't mess around. So you can't take 5 minutes to try to get an optimized view with DL. And if VL technology is immediately available and you're having trouble getting a direct laryngoscopic view right off the bat, you may convert that to a video laryngoscopic view pretty easily. And that's why I brought up the point about the DL and VL category in the previous slide, because it appears that at least half that started as DL may have been converted to VL partway through the intubation, which is okay. You should do what's right for the patient. But it may be inflating the impact from the Heaven criteria if all that could be done to get a good laryngoscopic view was not performed. Does that make sense? If not, please pose a question, and I am happy to talk about this in more detail. Okay, so what about the impact on intubation success? So you can see that individually the elements, although not all of them, that a lot of them had an impact on first attempt success. You'll notice in the top one that they do not look at first attempt success without hypoxia, which is really important. And so the anatomic elements of Heaven do have an impact on overall success, as you'd expect, because laryngoscopy is harder. The bottom one looks at whether or not the intubation success and how fast you got the tube in, right? Because that has a direct correlation with whether the patient desaturates. How Heaven does when you have to look at speed and first intubation success. And there's a correlation there as well. Not all the criteria are strongly correlated, but most of them are. All right, so when they did their multivariable analysis, this is sort of what fell out as predictive criteria or predictive elements of Heaven. So when you are just looking at failure of first intubation attempt, you can see that the Heaven criteria, when you look at things like body habitus, anatomic challenges, in neck immobility, etc., as expected, have an impact on first intubation attempt success. When you start to look at first intubation success without desaturation, i.e. you are adding in the speed element, how fast can you get the tube in, or how well the patient was pre-oxygenated, you can see that things like hypoxemia become significant, although exsanguination never became significant. The other elements, the physiologic impact of Heaven tends to start to come into play. So what are the limitations? There are not a lot of limitations. I think the results are common sense. The only thing that may be, I don't want to say inflating the results, but you probably wouldn't find this degree of impact if you were applying Heaven to a set of intubations performed in a different setting. So I don't think you would find this as impactful in in-hospital intubations, because we know that VL and DL have higher rates of glottic exposure than this, and so the differential impact of Heaven being present or not may not have the same results. However, this is studied in the pre-hospital setting, and it seems to work in the pre-hospital setting. So, I think the take-home message here is that Heaven is as reasonable a collection of difficult anatomic and physiologic elements as any other mnemonic. It is comprehensive, it covers a lot that you need to be worried about, and it seems to be a reasonable pre-hospital tool. The other is that when a patient is Heaven positive, it is clear that VL does better than DL. So not only will it predict difficulty, I think it also has some suggestive ability for the operator. So if you have someone, in my mind, one of the take-home points is that if you have a patient who screens positive for Heaven, you should not be using DL. unless DL is really the only thing you have available to you. VL is what you should be using, and that really translates to in-hospital, ICU, and pre-hospital settings. So it looks like we actually have a question. So let's pause here for a second. Excuse my cursor that's moving because I want to explode this a little bit. So the question from Will is, and I think he's intrigued by what I mentioned as the laryngoscopic attempt that was technique that was suggested if a patient was screened Heaven positive. And Will asks, is this anti-epiglotoscopy technique described anywhere else? And yes, it is. I do not have evidence to tell you how it works compared to epiglottoscopy. However, the Miller blade, it turns out, was originally designed to be used exactly this way. You straighten the patient's neck out. There's a fully blind insertion where the tip of the blade ends up in the cervical esophagus. You lift and then withdraw on the way out. And then as the arytenoids fall off the end of the blade, the idea is that the airway would then sort of drop into view. So a lot of people use Miller blades, like Max, however, opting to perform epiglottoscopy on the way in. And I'm not a big Miller user in general anyway, but yes, this has been described before, and as I understand it, the way a Miller blade was actually originally designed to be used. So thank you very much for that question. All right, so again, reasonable pre-hospital tool, seems to do a good job at predicting difficulty in the pre-hospital setting. There may be some inflation of impact based on whether or not operators aborted a difficult direct laryngoscopic attempt in lieu of video, and there may be a little bit of that in the paper, but it's a good thing to consider if you are a pre-hospital airway manager. Okay, so let's move on. That was there was a lot buried into that paper, even though on the surface it seemed like it was going to be just another observational study. There was actually quite a bit to talk about. All right, so let's move on to the clinical scenario. So as intubation preparations begin, one of the paramedics appropriately becomes very concerned about the patient's oxygenation. BiPAP use is limited because of blood pressure and shock issues. He's currently sat in, if you remember, 90% on face mask oxygen. And he starts to remember a TWOG. And I just made that up. It may be a thing, but as I was making the slides, I said that, I bet this is a thing. TWOG is a Twitter post commenting on someone else's blog. If people are familiar with the leveling of evidence, A, B, and C, this is level W. But this person does remember TWOGs about RSI and how many people are proposing giving the neuromuscular blocking agent before the sedative to minimize the apnea time. And is that a good idea? Should we be doing that? Does it make a difference, actually, in the apnea time in any one patient? So my next question for you is, should you give the neuromuscular blocking agent first in this patient? Yes, no, maybe so. All right, so most of you say no, although it's pretty close. I mean, we don't have anything that's over 50%. 32 say yes, and 23 say maybe so. All right, so let's talk a little bit about this RSI medication order issue. So what is the idea behind this? Why is this even a thing? Why is this even a discussion, right? I mean, RSI is classically sedative followed by neuromuscular blocking agent. And the reason why it's that order, or we give meds in that order, is because you want the patient to be asleep before they are paralyzed. And that works very well for 99.9% of the patients. However, for patients where apnea time of 30 seconds versus 20 seconds may make a difference in their overall hypoxic state, people have started to discuss the idea that maybe the neuromuscular blocking agent should go first. It takes a little bit longer to act than some of the rapidly acting sedative agents outside of midazolam. But etomidate, for example, if you were to push rocuronium and etomidate together, the patient would be asleep well before they're neuromuscularly blocked, and that's what you want. But if you wanted to time the onset of the medications more closely, then does it make sense to give the rocuronium first? That's going to take 60 seconds to work. The etomidate is going to take 30 seconds to put the patient to sleep. So assuming a 30-second delay in switching syringes, both drugs start to work at exactly the same time. Because when you give the induction agent, the idea is that the patient becomes hypopneic before they're paralyzed, which the degree of impact on the oxygen saturation is now added. It's additive instead of having the onset of the medications be more aligned. So the question is, does that make sense? Do you want to run the risk of potentially having a blown IV, for example, halfway through RSI, and now you've been able to give the neuromuscular blocking agent, but for some reason the sedative now won't push through? I mean, do you want to take that risk? And more importantly, does it even make a difference? Should we even be touting this because there's something clinically meaningful that comes from it? Well, that question has started to be tackled by this paper. And this is in Academic Emergency Medicine, just came out. And this is the drug order in rapid sequence intubation. We've seen papers from Brian Driver and Rob Reardon in his group before. Actually, the focus of our last webinar was his randomized controlled trial of bougie first versus stylet and tube intubations. And it turns out that this is a planned secondary analysis from data in that randomized controlled trial. All of the patients that were analyzed were rapid sequence intubation patients because they had to have patients that received sequential drug administration, and they had to receive drugs within 30 seconds. So if they were sedation-only patients, they were not included. They also only wanted first attempt success patients because they didn't want other issues around the process of intubation, ones that were complicated, to confound the impact of the drug order in the results. So they wanted very straightforward first attempt success cases. That left them with a total number of 562 encounters that they analyzed. The primary outcome was apnea time, and the apnea time was defined as the time from first drug administration, whichever one that was, to removal of the laryngoscope at the end of the intubation attempt. That was the time window. Secondary outcomes were hypoxia and first attempt success. These times were measured prospectively by a research assistant who was called in to stand and observe the intubations, and they timed with a stopwatch the different process points of the intubation. So they feel like they have very accurate time data. They then performed 2 sensitivity analyses to show the impact of their exclusions. And the exclusions were, again, that they eliminated patients who had more than one intubation attempt to successfully intubate. And the other is patients who had sequential drugs, but they were given at a longer time interval, more than 30 seconds. Here is their enrollment algorithm. So you can see that they ended up with 562 patients. Turns out that, interestingly, I find this very interesting, how regional and cultural airway management can be, that 153 of the 562 received sedative agents first, what I would consider sort of traditional RSI drug administration order. Most of them, 409 of them, received the neuromuscular blocking agent first. Now, I don't know if they do this because they believe that that's better, if they do it because they feel like it makes them unique or if it puts them on the cutting edge. I have no idea. But I do find that interesting, and I think that that is very different from many other centers. If you were to take a look at any one academic center, I know at Brigham, for example, I don't know a single person here who gives the neuromuscular blocking agent first. I think mostly because they're worried about what happens if that's the only drug that's able to be administered, because then you're left with the really unfortunate situation of someone being paralyzed and not being sedated. Not that that happens that often, but still it's theoretically possible when you do it that way. And you can see the numbers that were included in the sensitivity analyses down below. So these are the unadjusted study outcomes. You can see that they list total intubation time, attempt duration, hypoxia, and first attempt success. And the bottom line is that whether the sedative or neuromuscular blocking agent was given first, there was really no significant difference between the orders of medication administration. Now, when they did a multivariable analysis, you can look either at the table or at the graph at the top. I really like the pictorial display of the data in this figure in the left upper part of the screen. Each column, of course, each little line is patient-level data. This shows that the slopes are very similar. As we mentioned, there were more patients who received the neuromuscular blocking agent first than sedative. And for the primary endpoint of how long did it take for the patient to be tubed successfully, in other words, how long was apnea from the time of drug administration to laryngoscope withdrawal, they were about the same. The difference, turns out, was 6 seconds, which turns out not to be statistically significant. When you look at the other elements that they measured and their impact on the time of apnea, you can see, this is in Table 4, that the neuromuscular blocking agent with sedative first used as the baseline, you can see that when the neuromuscular blocking agent was administered first, there was an overall decrease of 6 seconds in the total time of intubation, but that was not significant. When rocuronium was administered in comparison to succinylcholine, there was 4 additional seconds, and you can see the other elements down there. The one that probably had the most impact was when the patient was intubated under direct vision. Using the video screen takes a little bit more time because you've got to find your tools on the screen. There's some hand-eye coordination that kind of starts to creep in. And so it turns out that the intubation was 10 seconds faster when a video screen was not used. So these, of course, are patients who had fairly easy, straightforward laryngoscopy, and there wasn't a problem with getting a direct glottic exposure. So limitations of this paper, number one, it was a small sedative first group that impacted the strength of the modeling, which they admit in the paper. There was no post-intubation interviews of the patients who were intubated. In other words, of the 409 patients who were paralyzed first and sedated after, was there some recollection from the patient that that's actually what took place? It's very tough to do that. I think that in order to really have a definitive statement about whether or not we should be changing our drug order, you not only have to show that there's a clinical need, i.e. the apnea time in hypoxic patients is significantly reduced, which they didn't find, but you also have to make sure that the patient's not aware that they're being paralyzed. And there was no philosophical discussion in the paper about that. I think the take-home point is there's basically one, which is there's no difference in the apnea time based on the order of administration. And in my mind, there's no reason to switch the traditional order because it doesn't buy you anything clinically. And there's always I agree this will be rare, but always the chance that the patient remembers it, or there's some access issue that rears its ugly head in the middle of rapid sequence intubation. So the neuromuscular blocker is administered, but the sedative is not for some crazy reason, and that would be horrible for the patient, in my opinion. If there was a very strong clinical impact, we could start to debate that philosophical piece. But since there's also no clinical impact based on this paper, I think there's no reason to switch that traditional order. Okay, so let's move on to the last part of the clinical scenario. The patient is intubated with etomidate and rocuronium in standard order. Intubation is successful, so kudos, and the patient remains, quote, calm for the rest of the flight. 20 minutes later, when they arrive in the ED, the staff, of course, is getting pass-off from the flight paramedics, and one of the ED staff asks, what ongoing sedation has the patient required after intubation? Very good question. We didn't mention that. So should this patient have received post-intubation sedation? Yes, no, maybe so. Good. So, okay, so most of you say yes. 25% of you say maybe so. It's good that no one said no, because I think you either believe that patients deserve post-intubation sedation, which they do. However, sedation sometimes has its side effects. And the one that I think is most concerning, especially in someone like this who's got low blood pressure and is a polytrauma patient, is what's its impact on the patient's ongoing hemodynamics. Now, assuming they're getting resuscitated, they're getting fluids, maybe pressors are started, the blood's given, I mean, who knows? If you answered C because of the blood pressure, I don't disagree with you. You're going to be surprised, though, because no one chose B, that it happens more often than you think. So let's talk a little bit about post-intubation sedation. Now, this is a paper that has been accepted for publication. It's available to be viewed online. It's not in print yet. They tell us it's going to be probably a year, actually, before it's printed. This is a National Emergency Airway Registry paper. If you're familiar with NEAR, we coordinate a 25-center observational ED registry, coordinated out of Brigham. The authors are listed there, which include Olga Lemberski, Justin Carlson, Ron, and myself. This was a prospective observational registry I already mentioned. We also have fairly large numbers because we're lucky enough to have very engaged site investigators enrolling centers. At the time that we did a snapshot of this paper, we had 11,748 encounters that were analyzed. We looked at the rates of post-intubation sedation in all comers and in non-arrest patients, because we thought that the largest group of patients who were likely to not receive post-intubation sedation after RSI would be patients in arrest, because if they're arrested, they don't need sedation as a general rule. So we did a stratified analysis excluding non-arrest patients. Our primary endpoint was the rate of post-intubation sedation, and the secondary endpoints primarily were to look at or discover, hopefully, factors predictive of post-intubation sedation, or more importantly, not getting post-intubation sedation. So the way that we procured this information in the data collection tool is we actually have a discrete question at the end that asks whether or not a list of medications were administered to the patient in a 15-minute time window after RSI. And we chose 15 minutes because whether or not you used etomidate or propofol, which are the two most common sedative induction agents in our registry, after 15 minutes, those patients are starting to become aware again of what's happening if they weren't fully unconscious at the time of intubation. So assuming that they received rocuronium for at least half of them, we know that from our registry, or even succinylcholine, it's possible that these patients are starting to wake up but would still be paralyzed. So we thought of a 15-minute window would be good. Overall, 77.5% of patients received some post-intubation sedation. Now, we have lots of things listed, so it's a pretty comprehensive list. It includes midazolam, propofol, etomidate, fentanyl, standard things that you might use to sedate your patients. There's also a checkbox to discreetly, or not discreetly, but to definitively say, no, we did not give anything. We found that about 900 times that this area was left blank, which is about 7% of the encounters. So not a lot, but not insignificant. And that's a limitation of the paper. But after that, people either wrote they did not or they did. So it's, although these numbers may not be perfect, they're probably not that far off. So when you look at table 1 here, and this is all comers, looking at intubation characteristics stratified by patients receiving sedation and patients not receiving sedation, they're pretty similar, but a few things fall out as being significant. And you can see the overall rate of patients not receiving sedation was 22.5%. So between 71 and 80%, just saying post-test, did receive sedation. The things that fell out as being predictive, number one, was pre-intubation systolic blood pressure, right? If you're worried about hypotension and you don't want to cause circulatory collapse, they're more likely not to get post-intubation sedation. That makes complete sense to me. Patients in arrest prior to intubation was highly predictive of not receiving post-intubation sedation. It's probably more accurate to say not requiring post-intubation sedation. And then the technique, RSI versus not RSI. If you received rapid sequence intubation, then RSI, you were more likely to get post-intubation sedation, which makes sense. However, the paralytic that's used has an impact. You were more likely to receive a dose of post-intubation sedation if succinylcholine was used, as opposed to rocuronium. And that also makes sense, right? You can imagine that when the patient starts moving around after 10 or 12 minutes and they start turning their head or grabbing for the ET tube, people are going to sedate that patient. But we've all seen or received patients who were, quote, sedated with pancuronium or sedated with rocuronium or sedated with vecuronium. And they arrive tachycardic, and people are starting to wonder why they're so tachycardic, and it's because they're awake and they're paralyzed. Now, we repeated that analysis, removing the patients who probably confounded some of this, i.e. the arrest patients. Right? If they didn't require post-intubation sedation, then it was a conscious decision to not give it, or it wasn't something that was missed. It was they just, by the nature of their illness, didn't need it. So when you removed arrest patients, it still was freakishly high, actually. Patients not receiving sedation, excluding all arrest patients, was still almost 14%. And the same predictor still applied. So if you were hypotensive, you were less likely to get post-intubation sedation. And if you had a long-acting paralytic on board, you were more likely. In addition, trauma was correlated as well. If you were a medical intubation, you were more likely to get post-intubation sedation. If you were trauma, you were not. And that is probably because many of the trauma patients had head injury. And because they had head injury, they had very depressed GCS at the time that they were intubated, or there was some perceived need that their sedation needed to be light so that someone could follow whatever neurologic exam they had. So what are the limitations of this paper? And there are some. Even though it's my paper, there are limitations. One is the 15-minute window. Was that really the right window? And is that too strict of a cutoff? So, for example, if we gave people 20 minutes, would we have found the same results? I think once you get beyond 20 minutes, you really, a lot of patients, especially with succinylcholine, especially with rocuronium, if you used etomidate as the induction agent, they're going to be paralyzed and they're probably going to be awake. But maybe 15 was too strict. There's always recall and recording bias when you have an observational registry, and we have 90% system-wide compliance. That's pretty good in a multi-center registry, but it's not 100%. The take-home message here is be very cognizant of post-intubation sedation, especially when patients are head injured or rocuronium was used, because it is easy to miss being prompted for post-intubation sedation if the patient's not moving. And that's going to happen with longer-acting neuromuscular blockers. So we really need to be on top of this, especially now knowing that ROC is an independent predictor of not receiving post-intubation sedation. And these rates are high. I mean, these data come mostly from academic centers where you'd feel that people are very on top of this stuff. But even in academic centers, we're missing this at least 10 to 20% of the time. Okay, so in summary, Remember these three things. Post-intubation sedation occurs less often than we hope, so please pay attention to that. Order of RSI drugs doesn't matter in terms of apnea time based on that second paper. And when a patient screens positive for HEVN, expect that laryngoscopy is going to be more challenging, and you should opt for video laryngoscopy. All right, so let's break here for a second and see if there are any additional questions before we move on to the post-test. So we have a question from Keith. It says, it seems the drug order affects overall length of intubation time rather than just apnea time. If a sedative is effective in 15 seconds, and the neuromuscular blocker in 30, then the neuromuscular blocker first should reduce the overall time of intubation. Well, I think that's exactly what I was saying, Keith, which is that if you could better align the onset time of these medications, then you don't have that lead-in to neuromuscular blockade where the patient is sedated and becoming hypopneic, which could have an impact on their oxygen sat before they have intubating conditions that allow you to actually intubate them. So I agree with you, and that I think that's another way to think about this, is they were wondering whether doing that has a significant impact on, call it length of intubation, call it length of apnea, so the time that the patient becomes hypopneic or apneic to the time the tube is placed. So I agree. I think what they found, though, is that the order, because RSI is by definition a process by which the medicines are given by rapid IV push with no time delay in between. It's one syringe push, second syringe push, that there's very little differential impact by the order in which the meds are given, I think was their take-home message. And then a follow-up question from Keith suggests, wouldn't ketamine be the best sedative since it supports the catecholamine effect? And for this particular scenario, I would agree with you that someone who is acutely hypotensive and you're resuscitating them with fluids, you're giving them blood, but they haven't been sick for 2 days, sort of the dwindling septic patient who now comes in with a pressure of 70 and their adrenals have been squeezed for 48 hours. Those are the patients that actually can have circulatory collapse from ketamine just like any other patient. But this, you're right, for this patient, ketamine would be a great option. Okay, I don't see any other questions at this moment, so let's move on to the post-test. You can always put something in there afterwards if you want. All right, so this is actually, say, post-test question number 1. How often is post-intubation sedation appropriately administered after emergency department RSIs? So how often is it given, not how often is it withheld? A, greater than 90%, B, 81 to 90, C, 71 to 80, or D, less than 70%? I can't remember how everyone did. I think we're a little bit better. So you should be seeing the results now. The single best answer was C, and that is the correct answer. If you remember, the rate of overall post-intubation sedation for RSI in the emergency department was 77.5%, so the correct single best answer would be C. Okay, post-test question number 2. What is a risk factor for not receiving post-intubation sedation after RSI? A, head injury, B, rocuronium, C, hypotension, D, all of the above. All right, so with 60% voting, 90% of you chose all of the above, which is the right answer. So trauma, hypotension, rocuronium use, and in particular, trauma probably because of head injury and altered GCS. All right, post-test question number 3. Which of the following is true regarding apnea time and the order of administration of RSI meds? A, when the induction agent is given before the neuromuscular blocking agent, the apnea time is prolonged. C, you should give the neuromuscular blocking agent first, since it reduces apnea duration. C, it should be given alone, because that's the shortest. Or D, the RSI med order does not influence significantly the apnea time. All right. Yes, pretty close to 100%. That's good. So 96% said D, that is the single best answer. And then which of the following is true regarding the HEVN criteria for difficult and failed laryngoscopy? A, HEVN is used to predict the likelihood of patient death following emergency intubation. B, 4 more HEVN criteria means RSI should not be performed. C, if someone's completely HEVN negative, then DL is better than VL. Or D, the more HEVN criteria you have, the more likely you are to have difficulty with laryngoscopy and intubation. Excellent. So 96% said D. That is the single best answer. I think I think we did much better in the post-test than we did in the pre-test. All right. So I would just like to thank everyone for attending. Let me see if there are any other questions that have popped up in the meantime. There are not. So I would say thank you very much for attending. Hold on one second because I need to let you know when the next webinar is going to take place. It is September 19th. I forgot to put that slide in there. I apologize. So thank you. We will see you September 19th, 2019 at 2 p.m. So thank you very much. And we will see you next time.